Good
Yes.
afternoon, viewers. On behalf of Doc Plexus, I am Kajal Mukherjee, welcoming you all to this session. This session is in part of an APSA, that is uh, Andhra Pradesh Pulmonology Association, Seema Andhra Association, and this is a continuous process. So today, for today's sessions, we have our all esteemed pulmonology expert from pan India. So let us begin with this session. Thoracoscopy's interventions have emerged as an pivotal advancement in minimally invasive thoracic surgery, offering both diagnostic and therapeutic benefit. This procedure provides direct visualizations of pleural cavity, lungs, allowing precise management of conditions such as pleural effusion, pneumothorax, and early stage of lung cancer. For today's interesting session, I hand it over to Dr. Ramakrishna sir. Dr. Ramakrishna sir will introduce the
Yes.
speaker and other esteemed guests. So over to you, Dr. Ramakrishna.
Thank you very much, Mr. Kajal. So I'm as APSA president. I'm very happy to introduce our esteemed colleagues, speaker, Madam Gayatri, um, uh, today. And this has been a second webinar. The first webinar was conducted by Dr. Aruna a month ago. And this is all because of the efforts of Dr. Gopal Krishna and the team of APSA. So this is today is going to be a wonderful session. And so we got three important professors from Andhra Medical College, the premier institute where the post-graduation of pulmonology started way back in 1978 with likes of Dr. Ravindra Babu. And now this we are going to have a very wonderful session with Dr. Gayatri. So I hope I'm correct with her name.
Yes, sir. Yes, sir.
Yes, sir.
Dr. Gayatri, I'm first time seeing you, heard of you. So you have come out as a professor of pulmonology. Nowadays in Andhra Medical College, a very prestigious institution. We got veteran Dr. Sunil, who has been the professor and the head of the department of, and superintendent of GHCCD, and Dr. Neetu Chandra Madam. She is well known to us. She is from Tirupati. Now I'm happy that she is in Vizag as they are the moderators. And we have well-earned first DM of pulmonology in the government service in Andhra Medical College. I congratulate you, madam. So on this occasion, so we're going to have a beautiful session on thoracoscopy. Thoracoscopy has become a very important part of pulmonology practice now. So gone are the days when we are doing a blind biopsy with Abraham's needle or Koch's needle. Now we have got definitely thoracoscopic biopsy. We can choose the area and choose the place for biopsy. So useful for diagnosing for primary and secondary lesions in the pleura. So and also for many cases, sometimes when you are not able to distinguish whether it's tuberculosis or malignancy, thoracoscopy has definitely given us a good lead to come to a diagnosis. So I congratulate the speaker, Dr. Gayatri, and I hand over the mic to her for her wonderful session today.
Good evening, everyone.
Let me take the pleasure of
Sir,
thanking.
am I audible? Sir,
Yeah.
am I audible?
Yes, you are audible.
Good evening, everyone.
Just a minute.
Thank you very much for your kind introduction.
Yeah, and Dr. Gayatri has also completed DM Pulmonary Medicine, sir. She has just joined from the St. John's Medical College of Bangalore, and she is now heading the 5th unit of Pulmonary Medicine, Andhra Medical College. Thank you, sir. Thank you. Over to you, Gayatri.
Thank you, sir. First of all, I would like to thank the APSA organization for giving us the Andhra Medical College this opportunity. Now I'm going to speak on thoracoscopic interventions. This is the overview of my presentations. The learning objectives are a brief history of medical thoracoscopy, indications of medical thoracoscopy, the diagnostic utility and therapeutic utility, contraindications, procedure, the endoscopy equipment, prerequisites and procedure steps, then complications of the procedure and recent developments in medical thoracoscopy, and conclusion. Sir, am I audible?
You are audible, Gayatri. Go ahead.
Yes,
Sir,
sir.
అందరూ కొంచెం మ్యూట్ చేసుకుంటానే just request, sir.
Coming to the evolution of the thoracoscope, so the person in this picture is the Hans Christian Jacobius. He's the father of thoracoscopy. In his pioneer paper, that paper on the possibility to use cystoscopy in the examination of serous cavities. He published that paper in 1910. He did a cystoscopic examination of the pleural cavity in a tuberculosis patient. Since the starting of looking into the pleural cavity the first time in 1910, after that till 1950, this thoracoscopy or evaluation of the pleura is mainly used for the treatment of the tuberculosis for creating an artificial pneumothorax. So it was also called the Jacobius operation. And in 1925, he also did infection, the tuberculous infections to lyse the adhesions, that is to treat for empyema also, the thoracoscopy was used. And later, after the invention of the anti-tuberculosis therapy in 1950, the incidence of TB cases are decreased and there is a specific treatment. So this procedure was, since then it is used by many European physicians as a diagnostic tool for various diagnostic evaluation of pleura and other mediastinal and lung diseases. And in first time in 1963, it was also used for a talc powderage. So the talc powderage was first started in 1963. So from the 1950 to 1990, this was procedure done by the physicians, the respiratory physicians, mostly in the European physicians. In 1990, the same procedure was used for a therapeutic purpose by doing a minimally invasive procedure. So in 1990, VATS was established. And after that, in 1994, because of this, there is a confusion between thoracoscopy, whether medical thoracoscopy or pleuroscopy, and there are different terminologies, pleuroscopy, thoracoscopy. But in 1994, the first medical thoracoscopy the term was coined. This to differentiate between the VATS and the medical thoracoscopy, where there are two different scenarios, where it will be done, and the indications also different for VATS and the medical thoracoscopy. And since 1994, it has evolved till to date. Coming to the indications of the thoracoscopy, so predominantly thoracoscopy is a second most diagnostic tool after bronchoscopy. So it is mainly used in the management of pleural diseases. So undiagnosed pleural effusions, which are defined as pleural effusions which were not established any diagnosis either by history, clinical examination, radiology, or by pleural fluid cytology and biomarkers. So those so most common indication for medical thoracoscopy is undiagnosed pleural effusions, and also in spontaneous pneumothorax and pleural infections like empyema. And there are some uncommon indications which were previously done. So these are lung biopsy, sympathectomy, and pericardial fenestration for the treatment of pericardial tamponade, foreign body removal, and for pleural abrasion or decortication. So again, the indications can be medical thoracoscopy is predominantly diagnostic indications, as already I said, that undiagnosed pleural effusions. Among them one is the suspected malignant pleural diseases like metastatic lung cancer with pleural effusion, metastatic pleural effusions, or malignant mesothelioma. And other diagnostic indications are suspected benign pleural diseases like tubercular pleural effusion or other benign pleural disorders. Coming to the therapeutic indications are very few with medical thoracoscopy. So these are the talc powderage and adhesionolysis in case of empyema. So indications we have already seen. So if we see this table, if we observe this table, these are the indications for thoracoscopy comparing from 1971, that is the time of initial times of thoracoscopy, until 1996. If you observe this, the indications for medical thoracoscopy, especially in cases of malignant pleural effusions, the indications are raised from 39% to 68%, whereas in other conditions like tuberculosis, diffuse lung diseases, or localized lung lesions, just all other mediastinal diseases, the use of medical thoracoscopy for diagnostic indication has been decreasing. So coming to the role of medical thoracoscopy in undiagnosed pleural effusions. So at least 25 to 40% of the pleural effusions remain undiagnosed in spite of the radiology and pleural fluid cytology and biomarkers. So the role of medical thoracoscopy is because it has a high diagnostic yield in malignant pleural effusions as well as in tuberculous pleural effusions. Then there is a higher yield in case of tuberculous cultures when compared to the thoracentesis cultures. So, and also in benign undiagnosed benign pleural effusions, also medical thoracoscopy has a role, especially this is for exclusion of the underlying malignancy or tuberculosis with a high probability. And other than that, also that medical thoracoscopy has a role in staging in lung cancer and diffuse mesothelioma. And because of, when compared to the closed pleural biopsy, the biopsy specimen is very large and it is like guided biopsy. So which can be used other than for the diagnostic purpose, like determination of hormone receptors in case of carcinoma breast with pleural metastasis, or for mutation analysis in lung cancer, especially non-small cell lung cancers. So the diagnostic accuracy of medical thoracoscopy is 98 to 100%. But from studies to studies, it is variable, but overall it is between 98 to 100%. It also differs from underlying disease, for example, in tuberculosis and malignancy. So the application of medical thoracoscopy today allows the simultaneous, along with the diagnostic, also allows the insufflation of the talc powder, which is currently offers the best results in case of fluorodesis treatment. Further therapeutic advantages include complete fluid removal and evaluation of re-expansion capacity of the lung. And in case of fibrinous loculations in tuberculosis and complicated parapneumonic effusions, they can be easily lysed and thus creating a single pleural cavity which can be treated more efficiently. Next thing, the parietal pleural biopsy is rarely needed in case of transudative effusions of unclear etiology, but they can be considered on a case-to-case basis, because in some cases the diagnosis we may not get in spite of thoracoscopic biopsy. So those cases should be followed for some period. So sometimes they may turn into any malignant effusions, but in case-to-case basis, they have to be decided on that. Coming to the malignant pleural effusions. So this is a short video. So in malignant pleural effusions, like we have many investigative modalities for malignant pleural effusions. And if we compare the medical thoracoscopy with the other diagnostic modalities like needle biopsy and diffusion, if we do a closed needle biopsy, the diagnostic yield is only 44% because of reasons like because of the the distribution of the pleural metastasis in case of malignant pleural effusions is predominant. It is not uniform. The distribution is not uniform, and it is predominantly in the lower areas, especially in the posterior costovertebral parietal pleura. So if we do a closed pleural biopsy, the diagnostic yield is 44%. And if cytology, if we do, the diagnostic yield is only up to 62% because it depends upon the number of the malignant cells exfoliated into the pleural fluid. If we combine both needle biopsy and diffusion, still the diagnostic yield is only 74%. Whereas with the medical thoracoscopy, because we are doing here, taking the biopsy under vision, the real time, so the diagnostic yield is 95%. If we combine with the cytology and thoracoscopy, it is 96. And if we combine all the three, the diagnostic utility in case of malignant pleural effusion will go up to 97%. So this is like a pleuroscopy showing parietal pleural nodular lesions. Next, along with the biopsy, so there are other advantages with medical thoracoscopy in case of malignant pleural effusions. First is to evaluate the pleural cavity so that we can find out the abnormal areas so that biopsy can be done. and guided biopsy can be done, as well as the fluid can be evacuated. And also at the same time, if there is a strong suspicion of malignant pleural effusion, talc poutrage can also be done. Coming like the thoracoscopic character, these are the endoscopic pictures of a pleural cavity. So the characteristics of pleural malignancies, the first one, this one is the normal pleura, where it is very transparent and we can see the vessels, ribs, and the muscles. Whereas in case of malignancy, we can see the nodules, polypoidal lesions studding the parietal pleura, candlebox drops, or mushroom-like lesions. And sometimes this will also help in staging of the lung cancer. This is the collapsed lungs. And here, if we see there, the visceral pleura, it is looking, that is the surface of the lung looking like lymphangitis. So by this abnormal area, so the biopsy can be directly taken from the abnormal areas to get a high diagnostic yield. Coming to the metastatic lung cancer, that is a lung cancer with pleural metastasis, which is most common with the non-small cell lung cancer. Presence of pleural effusion indicates an unresectable disease. It can occur by direct spread, hematogenous, or lymphatic spread. So in 1/3 of cases, thoracentesis is not diagnostic. So all those cases, they require a pleural biopsy. Thoracoscopic biopsy has a high diagnostic sensitivity up to 98% and can simultaneously has added advantage of pleural palliation in the same setting, like a talc poutrage. And also it added advantage of accurate staging and molecular genome, because we'll get a larger biopsy specimen. So simultaneously we can send it for a molecular genotyping, which results in appropriate therapy. And it also advantage, if there is no evidence of pleural cancer is found, it may open up the possibility for the curative resection. Next is the diffuse malignant mesothelioma. Pleural fluid cytology, like a malignant mesothelioma, now the incidence of mesothelioma is on the increasing trend. So it emphasizes that there should be an appropriate diagnostic tool for early detection, because it has an impact on the survival. Coming to the other diagnostic modalities like pleural fluid cytology, it is very less sensitive, 20 to 50%. So it is not sufficient for evaluation. And coming to the closed pleural biopsy, similarly, it also has a low diagnostic yield, because in mesothelioma, we'll get by closed pleural biopsy, we'll get very small size biopsies. And so the historical gold standard for diagnosis of pleural mesothelioma was open biopsy, but this procedure is associated with significant morbidity. So to overcome that, the medical thoracoscopy is the diagnostic of choice with a diagnostic yield of 95%. So in this medical thoracoscopy, so like with a 5 or 7 mm rigid forceps is used to get the larger biopsy samples when compared to the malignant pleural effusions or metastatic lung cancer. In mesothelioma, we should get still more larger biopsy samples. And so to increase the diagnostic yield, if we use a semi-rigid thoracoscopy to increase the size of the, to increase the diagnostic yield by taking a larger samples, adjunctive techniques can be used. For mesothelioma, also like lung cancer, it is helpful in accurate staging, and also it has a prognostic advantage if we diagnose the cases early, because early diagnosis has impact on the survival. So this is a small video of a suspected case of malignant mesothelioma. So the parietal pleura, it is thickened and fibrosed. So thickened, nodular, and fibrosed, diffuse, it is looking like a pleural plaques near the diaphragm. Next is the tuberculous pleuritis. So tuberculosis, all we know that ours is in a tuberculosis endemic country. So among the undiagnosed pleural effusions, approximately 20 to 39% are tuberculous effusions. And if tuberculous effusions are not treated, 65% of them within 5 years, they may turn into pulmonary tuberculosis or with extrapulmonary tuberculosis. So caseating granuloma in histopathology and culture sensitivity of the biopsy specimen is the gold standard for tuberculosis effusion. So like if we compare similar to the other diagnostic modalities like needle biopsy, so in contrast to the malignant pleural effusions, the involvement of the parietal pleura in tuberculous pleuritis, it is a uniform distribution of nodular lesions. So the diagnostic, like when the closed pleural biopsy, we can get a good diagnostic yield. So with needle biopsy, the diagnostic yield is 51% in high endemic areas. And if we take the cytology, CBNAT or culture, it is 28%. The diagnostic yield is 28%. If we compare it with the medical thoracoscopy, the diagnostic yield is 99%. And if we combine the effusion needle biopsy and the medical thoracoscopy, the overall yield is 100%. So this is a picture showing a sago grain appearance of the parietal pleura. So if we target these lesions, the diagnostic yield is 99 to 100%. And also if we subject it for culture sensitivity, the culture yield also 60% when compared to the pleural fluid cytology culture, which is 29 to 30%. So the added advantage, like in high endemic areas, though we the pleural fluid ADA and gamma interferon or lymphocytic exudate, though the sensitivity and specificity of this pleural fluid analysis is high for diagnosis of tuberculous effusion, thoracoscopy is indicated because there is an rising trend of drug-resistant tuberculosis. So to get a good biopsy sample and to subject it for culture sensitivity and drug sensitivity testing, compared to the closed pleural biopsy or a cytology based on the cytology, the diagnosis. So it is preferable to do a medical thoracoscopy. So this is the tuberculous pleural appearance in case of tuberculous pleuritis. So this is the adhesions between the parietal pleura and the visceral pleura. Coming to the other benign pleural disorders, like a hyaline or calcified asbestos pleural plaques have a distinctive endoscopic characteristics. They appear smooth and white. And also in rheumatoid pleural effusions, the visceral surface usually shows non-specific inflammation and parietal surface has a gritty appearance. So basically in benign pleural disorders, the main goal of a medical thoracoscopy is to exclude the malignancy. And also recurrent pleural effusions of non-malignant etiology. In those conditions, when we are doing a medical thoracoscopy, talc powderage can be done in case of benign pleural effusions. Next is these are the diagnostic. Next is the therapeutic indication. So the most common therapeutic indication is the talc powderage. So it is indicated in case of malignant pleural effusion, recurrent non-malignant pleural effusions, and also recurrent primary spontaneous pneumothorax, where in which condition if the patient is not fit for a VAT surgery, they can be subjected to medical thoracoscopy for talc powderage. Thoracoscopic talc powderage, because it can be done under local anesthesia, this is a safe procedure, well tolerated, and when compared to the other modalities or VATs, it is low morbidity and cost effective. And also the recovery of the patients post pleurodesis by medical thoracoscopies from 5 to 7 days. So there is a classification of pneumothorax, thoracoscopic classification of pneumothorax was given by Vander Schuharen. Stage 1 is there is a normal lung. Stage 2 is with pleuropulmonary adhesions. Stage 3 with small bullae and blebs and thereof less than 2 centimeter in diameter. Stage 4 with numerous large bullae of more than 2 centimeters in diameter. Medical thoracoscopy offers the possibility to combine the chest drainage with coagulation of these blebs and bullae as well as pleurodesis by the talc powderage. Next, in case of complicated parapneumonic effusions, in the early phases, if the adhesions are not fibrotic, they're flimsy adhesions, so medical thoracoscopy has a role. So if we, for adhesionolysis, so to make it a single pleural cavity for efficient drainage. So once we decided to do a medical thoracoscopy after a proper indication, also we have to look for any contraindications to the medical thoracoscopy procedure. So the contraindications are the absolute contraindication and relative contraindications. The absolute contraindication means the single most absolute contraindication is uh, a lack of pleural space, which could be due to pleural adhesions, pleural thickening of unknown etiology, or a history of previous pleurodesis, or mesothelioma where both pleura are adherent to each other. So basically, when there is no pleural space, it is a contraindication for medical thoracoscopy. So there are many other relative contraindications. So patients with unstable cardiovascular status like unstable angina, recent MI, arrhythmias, and also it is not safe in advanced pulmonary fibrosis because of the high risk of air leak and significant hypoxia, bleeding diathesis, hemodynamic instability, allergic to anesthetics, cough, fever, and infection are relative contraindications. So in all these relative contraindications, we have to first stabilize the patient and then we can post for a medical thoracoscopy. And coagulation defects should be corrected before thoracoscopy. And in case of intractable cough, severe sleep apnea and obesity also causes challenges for the medical thoracoscopy procedure. So all complications related to them should be anticipated and appropriate action should be taken. And coming to the procedure, so the requirement of a medical thoracoscopy, so it is done in a endoscopy suit under sterile conditions. Along with the endoscopy suit, it should also have a pre-medication area. It should have a washroom adjacent to that, and an area for cleaning and sterilizing the instruments must be available. And the procedure room must have the following, like for monitoring, a multi-channel monitor for monitoring of vitals, and then is including the ECG monitoring, and the resuscitation equipment, the crash cart and the defibrillator, oxygen source, and then height adjustable procedure table should be there, suction equipment, trolley to hold the instruments, and facilities to display the patient's radiographs. So these are the various instruments required for the thoracoscopy. So these are the thoracoscopy instruments, trocar, cannulas, and this is the thoracoscopy instrument. And these are the barrels with 0 degrees, 30 degrees, or 50 degrees. And then this is the biopsy forceps, and these are plastic trocars. And this is the coagulation forceps, and we should need a suction apparatus. We should need a talc powderage and different electrocauteries. And we also should need an ultrasonography and the light source and the monitor. So these are the various auxiliary instruments needed for a endoscopic suit for thoracoscopy. So for the portal of entry, we should need a thoracoscopy. So prior to the procedure, when the patient is kept in the left lateral decubitus position, so we have to screen with an ultrasound chest to determine the safe point of entry to facilitate the procedure, so that to reduce the unsuccessful pleural access and also to reduce the complications. And also it reduces the duration of the procedures instead of repeated attempting for the portal of entry. So like it is a necessary, either an ultrasonography or a fluoroscopy is needed in the endoscopy room. Next, coming to there are two types of like thoracoscopies available. The one is the rigid thoracoscopy. So the rigid thoracoscopy, it is 27 to 30 centimeters length, the rigid part of the scope, with a 7 to 12 mm diameter. So there are either 7 to 12 diameter scopes are available, and the working channel is between 5 to 7 millimeters. When compared to the semi-rigid, they have a superior optics, and the advantages, we'll get a larger biopsy specimen because the working channel and the forceps are bigger, and we'll get a specimens between 13.9 to 24 mm samples. It allows taking of biopsies from very dense lesions also, because this is rigid, so it has a mechanical support. So from the dense adherent lesions also the biopsy can be taken, and this is more suitable when more elaborate procedures are indicated, like adenolysis, or if there is a bleeding, we can apply an electrocautery. And when it is necessary to control hemorrhage after biopsy, rigid thoracoscopy is the best option compared to the semi-rigid thoracoscopy. And the same time, it has a disadvantages also because of the rigid nature, less maneuverability. So if adhesions are there, we cannot see the proper view. And also because it is the size is the diameter is more, so it causes more pain and discomfort to the patient. The other advantages when compared to the flexi-rigid scope or it is less expensive compared to the semi-rigid, and it is more robust and have a longer endurance and needs less maintenance and repair. Next is the semi-rigid thoracoscopy. So it has 27 centimeters length. Rigid proximal portion is 22 centimeters, and the distal 5 centimeters is a flexible end. The outer diameter of the scope is 7 millimeters, and the working channel is 2.8 millimeters channel. So this semi-rigid thoracoscopy is almost like a similar to the fiber optic bronchoscopy. So because of this easy handling, because like bronchoscopy, many of us are aware of how to do a bronchoscopy. So it is the handling is similar to the bronchoscopy. So it lowers the threshold for the chest physicians. It maintains a clear optical field by allowing concurrent suctioning, and it has a flexible tip, so it can be maneuvered in different directions, 160 degrees anti-flexion and 130 degrees retroflexion, and into the inaccessible places. Unlike a rigid thoracoscopy, we can see through the deep gutters also, and it facilitates homogeneous insufflation of the talc when compared to the rigid thoracoscopy. And it also has disadvantages or limitations, because its optics are less resolution, and the specimens with this semi-rigid thoracoscopy are smaller, 4 to 11 millimeters compared to the rigid thoracoscopy. Next is the prerequisites for the procedure. So like we have to do a preoperative evaluation of the patient. So we have to take a detailed history regarding the comorbidities, any medications, especially uses of any steroids or uses of any anticoagulant agents, and history of any radiation exposure or occupational history also we have to take, and history of any connective tissue diseases and other comorbidities like renal, cardiac, we have to ask. And then physical examination, we have to do physical examination, especially with respect to the intercostal spaces, to have an idea about the portal of entry. So whether the intercostal spaces are sufficient to do a thoracoscopy, to introduce the trocar and the thoracoscope. And also we have to see if the patient is obesity, we have to anticipate certain complications. So physical examination, we have to see for the intercostal spaces. And next is the labs. So routine labs, CBC, RFT, LFT, serum electrolytes, PTINR, to look for any coagulopathies, and the routine any surgical screening, HIV and hepatitis B and C, and blood grouping and typing. So by labs, we can see whether any infection is there, any renal, any acidosis or chronic renal diseases. Because chronic renal diseases, patients may have a more tendency for bleeding. So we have to see all those things. Next, the cardiopulmonary function assessment should be done within last 7 days. ECG, any arrhythmias we have to see. And then if the patient has any respiratory diseases like COPD or bronchial asthma, we have to do pulmonary function test to see the vital capacity. Because the patient is in the lie down position, we will do the procedure. So to see the vital capacity, and then 2D echo if needed should be ordered. And then imaging, chest X-ray, PA and lateral views. But CECT chest is also mandatory, because CECT chest, like we can assess the how much quantity of the pleural fluid is there, and any septations or organization, any loculations we can estimate from the CECT chest, and also any other underlying conditions like involvement of visual pleura, any lung nodules or mediastinal structures, any lymph nodes, all can be assessed. Next thing is the ultrasonography chest and abdomen. Ultrasonography chest is also again to assess the amount of the fluid and any adhesions are there, to assess that. And abdomen is also important. This is to see for any abdominal causes of pleural effusion, and also to see any liver abscess. So the portal of entry is also assessed by ultrasonography chest or by the CECT chest correlating with the clinical condition. Next is the patient should be able to lie down in the lateral decubitus position. Then if the patient is on anticoagulants, they should be withheld. So it is dependent on the what type of anticoagulant patient is using. Based on that, we have to tell them that to stop the anticoagulants, and then pre-procedure 4 to 6 hours of fasting is needed, and the patient should be ideally hospitalized for a daycare procedure. Next, the pleural ultrasound should be performed and available also during the procedure, because in case of if we do an artificial pneumothorax to check whether the lung sliding is there or not. So to do that, to assess that, so during the procedure also ultrasound should be available in the endoscopy room. The procedure should be undertaken by a properly trained pulmonologist. A minimum of 2 other suitably trained healthcare personnel are required for assistance, monitoring, and administration of the intravenous sedation. All members of the team should be familiar with the procedure and have the knowledge, competency, and resources necessary to respond to an emergency situation. And written informed consent should be there. Next, coming to the pre-medication, local anesthesia and sedation and analgesia. So medical thoracoscopy is done under local anesthesia with conscious sedation. So local anesthesia used is the 1% lignocaine, about 20 to 25 ml can be used. And then for conscious sedation, that is conscious sedation means the patient is awake or arousable with a normal breathing pattern. For conscious sedation and analgesia, mixed anxiolytics and pain medications, pain medications will be used. So combination of benzodiazepines and opioids will be used. So benzodiazepines, either midazolam or lorazepam we will use, or opioids, either fentanyl or morphine can be used. And during and before starting the pre-medication, the monitoring should be started, and the monitoring should be continued throughout the procedure, and 1 hour after the procedure the monitoring should be continued. So the vitals should be monitored like BP, pulse rate, ECG, oxygen saturation, and respiratory rate. Coming to the phases of medical thoracoscopy, patient preparation. So the steps are patient preparation, pre-medication, positioning the patient, local anesthesia, and then trocar introduction. Then inspection of the thoracic cavity through the scope, and then after evaluating the thoracic cavity, multiple biopsies, and if needed, additional lysis. And once it is done, if any bleeding is there, hemostasis, and if needed, talc powderation. And then we have to keep the ICD, and then we have to keep it stay sutured. And then after that, patient should be monitored during the recovery phase. Once the procedure is like during the procedure and after the procedure, like we have to anticipate some complications. So to overcome the complications, we should know what are the complications. So medical thoracoscopy, though it is a safe procedure, it is associated with some complications. If not preoperatively, if not evaluated properly, it is associated with certain complications. So the overall complication rate, according to a meta-analysis, it is 2 to 6%, and of which minor complications are 7.8%, like subcutaneous emphysema, minor bleeding, entry site infection, transient hypotension, fever, and atrial fibrillation. Major complications are approximately 1.8%. These are persistent air leak, hemorrhage, empyema, pneumonia, and port site tumor growth. And the mortality is very less. And in few studies, it is 0.09%, and in some studies, it is 0.34%. So the complications are anesthesia and sedation related, hypoxia. So because of this, anesthesia and sedative agents may cause hypoxia, hypotension, hypersensitivity to local anesthesia, or respiratory arrest. And during the procedure, breathlessness can occur during the induction of the pneumothorax, pain at the site, hypoxemia, hypotension, hemorrhage, and injury to the other organs. Post-procedure complications, most common is the pain seen in 44% of the cases. Next is the re-expansion pulmonary edema, though it is rare. Then post-procedure fever, wound infection, subcutaneous emphysema, prolonged air leak, empyema, metastatic seeding to the chest wall, and mortality. So to minimize the complications, like if the patient has a refractory cough, we can delay the procedure. and careful selection of the patient by preoperative evaluation. If any coagulopathies, they should be treated first, and then any cardiac or chronic respiratory conditions, first the patient should be stabilized with optimum treatment. And avoid biopsy samples from the fissures and mediastinum, and also from the vascular bands and fibrotic bands. And if there is an hemostasis, like a bleeding is more than 20 ml, we have to ensure hemostasis by electrocoagulation. And immediately after the procedure, we have to start the chest physiotherapy. And then to prevent the tumor seeding into the wound site, radiation therapy with 7 grays per day for 3 days to the scar area on the post-operative day 10 for 3 days. Coming to the recent advancements in medical thoracoscopy. So this is a mini thoracoscopy. This is similar to the rigid thoracoscopy, but the size, the diameter is 5.5 mm with a mini telescope and with a working channel of 3.5 mm working channel. Like some studies comparing the mini thoracoscopy with rigid thoracoscopy, but it is not like mini thoracoscopy, the diagnostic yield is not comparable with the either rigid or semi rigid thoracoscopies. Next is the for biopsy guidance, there are a lot of adjunctive instruments. For example, like the pleural cryoprobe. So this is feasible with semi-rigid and good quality specimens. We can get larger samples, and it is less procedure time. And then there are studies comparing the cryo versus conventional with a diagnostic accuracy between cryo and the conventional is 99 to 96%. And the other one is the insulated tip diathermy knife. This is borrowed from the gastric endoscopy. So but there are studies using the insulated tip diathermy knife. But the studies, like a few studies, they have a discordant findings between the two studies related to this insulated tip diathermy knife. So this pleural cryoprobe and the insulated diathermy knife still not yet used because there is not much of evidence by using this. So still till now, they are not recommended yet. Next, the other biopsy guidance techniques like modification, like autofluorescent instruments, like that fluorescein either inhaled in case of pneumothorax or intravenous fluorescein is used for pleural effusions. In this, the fluorescein enhanced autofluorescent thoracoscopy, it enhances the traditional white light thoracoscopy. In case of pneumothorax, this high-grade blebs can be detected by using this inhaled fluorescein. In case of pleural pathologies, so the color, because of the enhancement of the vascularity, the color of the lesions will be, they will become red. So if we see the pictures, in this first picture, that in case of mesothelioma, it is looking normal with a normal white light scope. But in case of with the autofluorescent, so the abnormal area is highlighted and it is looking like a white color patch. In case of this nodules with a normal white light scope, and this picture is showing highlighting, that means they'll become, because of this high vascularity, they'll become more red with autofluorescent instruments. Next is the other biopsy guided techniques are using narrow band imaging and infrared thoracoscopy and confocal laser endomicroscopy. So these are all adjunct to biopsy guidance strategies, but all these strategies, like evidence is not there to recommend all these things. Next is the 3D medical thoracoscopy. So it has a angulation. So it has a 360 degrees we can see, and we will get a panoramic view of the pleural cavity. And also it has an advanced optics. So the resolution is very high. So if we see this image intrathoracic, like the whole of the thoracic cavity, pleural cavity can be visualized. And here on the visceral pleura, the lesions are much highlighted because of the advanced optics. And coming to the conclusion, medical thoracoscopy is a safe and second common interventional tool. So the most common indication for medical thoracoscopy is the acquisition of parietal pleural biopsy in patients with undiagnosed exudative pleural effusions. The diagnostic yields are best for malignant pleural mesothelioma. The sensitivity is up to 98%, and for tuberculosis it is 94 to 100%. and it is lower for mesothelioma, that is 75 to 90%. Talc poutrage for recurrent malignant and benign pleural effusions can be done with medical thoracoscopy. Medical thoracoscopy is rarely used for lung biopsy, phlebectomy, or pleural abrasion or decortication, and drainage of complicated parapneumonic effusions if organized, and foreign body removal or sympathectomy. So the major contraindication to medical thoracoscopy is effused pleural space and extensive pleural adhesions. So to avoid complications, proper pre-procedure evaluation of the patient should be done. Thank you very much. Next, what to do?
That's an excellent presentation, Dr. Gayatri. You
Thank
have covered almost all the aspects of the medical thoracoscopy. Thank you very much.
Thank you, sir.
Most of the slides are very good, and most along with them, the pneumothorax classification, mini thoracoscopy, and the usage of cryo is a very excellent, Dr. Gayatri. Congratulations, Dr. Gayatri.
Thank you,
Over
sir.
to you, Dr. Surya. Dr. Surya, madam. Surya Kumari, madam.
Sir, good evening to all.
Dr. Gayatri, can I request you to stop sharing? Yeah, that's better. Ma'am, continue.
Yeah, good evening to all. Thank you, Gayatri, for the vast and elaborate presentation on thoracoscopy. Shall we have a few points to be discussed, like in brief? Niti Chandra, ma'am, are you there?
Yes, madam, I'm there.
Yeah, welcome to the session. And can you throw some light on patient counseling and medical legal issues regarding the thoracoscopy nowadays?
Yes, madam. I think in these days, it's a very relevant question, because the thing is, we in India, especially in the government hospitals, we tend to take our patients' trust for granted. And, in India, over the years, patients have trusted us, and we have kind of taken it for granted. But nowadays, with increasing literacy and with even medical insurance companies increasing, and also the explosion of the internet, knowledge through internet, patients are becoming very much aware. And I think they are rightfully becoming aware. It is their right, so we shouldn't blame them. But at the same time, we should take our own precautions. So I had the unpleasant experience of being a board member for some medical legal cases, both in Nellore and in Tirupati. And during that time, I realized that though we do a lot of work, there are some small mistakes, and that because of those small mistakes, we might actually, kind of fall into the soup. So a few things I think are very mandatory. So first and foremost, counseling is extremely important. And that counseling has to be done right before the procedure. We have to explain the whole procedure to the patient. Preferably, I think counseling should be done not only with the patient, but also with the attenders if possible. And then we should explain the whole procedure, the pros and cons, and then what are the advantages and the disadvantages of doing the procedure, and also the risk benefit ratio, that we should tell them what would be the advantage if you do, what would happen if you did not do. For example, a procedure like medical thoracoscopy, we understand that it is a very extremely good diagnostic tool, but it is not the only diagnostic tool. And so sometimes we have to explain the risk benefit to the patient. And then also we have to explain to them the side effects and the complications, that which Dr. Gayatri very rightly pointed out, so many of them. And then immediately after the procedure, this I find lacking in, many of us don't do it so properly. I think we should document the whole procedure very well. It should be perfectly documented. And even post-procedure, we should document the vitals immediately post-procedure, the condition of the patient. And in my experience with the medical legal cases, I saw that the lawyers, they were comparing the doctor's notes with the nurse's notes. So this, I think, we don't know. So one small word of caution is that we should also make sure and just flick over and see the kind of, the vital chart. We should look at the vital chart, and we should look at the nurse's notes and make sure they are in coordination with what, what we have documented. So like it's not totally different. Like in one of the cases that I saw, the nurse has noted a temperature of 102 degrees centigrade. But in the doctor's notes, it said patient afebrile and perfectly wonderful after the procedure. So then that was pointed out. So such small things, we never bother about them. But I think that is one thing that we should do. And above all, I think, when we are talking to the patient, however, irritating they might be or however many ever questions they may ask, I think we have to maintain our cool and talk to them really nicely and counsel them, because often what ticks off the patient is our kind of, whatever situation we are, our behavior is very important to maintain our cool and calm. So I think that is all. And thank you.
Yeah, well said, ma'am. Every patient
Madam, I think we need to take a counseling for the open thoracotomy also at any point of time during the procedure also.
Yeah, conversion to surgical procedure rather than medical.
Yeah, in case that there is a complication, we need to progress it further. That is for any procedure. Thank you.
Thank you, madam.
Gayatri, can I ask you, even though it is an elaborative session, and any pre-procedural complications and any technical challenges during portal of entries like that? Dr. Gayatri?
Gayatri, unmute yourself. Unmute.
Yes, sir. Yes, sir. Right. Coming to the first question on anesthesia and pre-medication. So medical thoracoscopy is a safe procedure. It usually can be done under local anesthesia. So with local anesthesia and conscious sedation. Conscious sedation means the patient is awake, arousable with a normal breathing pattern. So coming to the local anesthesia, we will use a 1% Jailocan solution, 20 to 25 ml we can give, because 10 milligrams per ml it is. Maximum dose is 250 milligrams. So usually how we calculate is 3 milligrams per kg body weight we will calculate, and we have to give. And coming to the conscious sedation, usually we will give for analgesia and sedative effect. We give a combination of benzodiazepines and opioids. Benzodiazepines, we can use either midazolam or a lorazepam, but most commonly we use midazolam. So midazolam we will give either 0.5 milligrams or 1 milligrams initially we will give, and then we have to assess the sedation depth by sedation scores, which are available in the endoscopy suite. So based on that, we can increase incremental doses. So we can repeat again 0.5, 1 milligrams like that, but maximum 3 to 5 milligrams we can give midazolam. Coming to the opioids, most commonly we use a fentanyl. Fentanyl, we usually will start with 25 to 50 micrograms we will start. And depending on the requirement, if the patient complains of pain, mainly predominantly this is for analgesia. So if the patient is still complaining of any pain, we can increase the dose. So same also, this also we can give in incremental doses, 25 to 50 milligrams we can repeat. So the maximum dose is 25 to 150, up to 150 micrograms we can give. So these midazolam or fentanyl, we have to give a slow IV, and this is about the conscious sedation. And some like pre-medication to avoid any vasovagal attacks, some people will give injection atropine, but that is an optional thing. Next thing, these commonly used drugs like fentanyl or midazolam are associated with hypotension and hypoxemia. So the patient should be monitored before giving a anesthesia medication, sedation. We have to baseline vitals, we have to check. And during giving this sedative medication, during the procedure and post-procedure also, we have to monitor the vitals carefully. The BP, saturation, respiratory rate, and pulse rate. Next, coming to the next question, the challenges during the portal of entry. So like the portal of entry, usually we will do in the axillary triangle, that is the safe triangle. For medical thoracoscopy, so we can do from a 3rd intercostal space to 7th intercostal space, depending on the underlying condition we have to choose. For example, for pneumothorax, we have to choose either a 3rd intercostal space or a 4th intercostal space, because we can best visualize the upper lobes where the blebs or bulla are present. Whereas in case of suspected malignant pleural effusions or suspected mesothelioma, we have to go little down, that is from 5th or 6th spaces, because the metastases are more common in the lower zones of the lung in the posterior pleura. So that is about the portal of entry. So while doing the for first selecting the portal of entry, we have to take help of the ultrasonography. So by ultrasonography, we can quantify the amount of the fluid, and also any septations or any adhesions or there any organization we can see. We can see the pleural thickening also by ultrasonography. So based on the ultrasonography, after the patient is kept in the lateral decubitus position, with the ultrasound guidance, we can mark the point of entry to avoid complications or challenges associated with a portal of entry. So we'll get during different case scenarios, we will come across and challenges while doing the portal of entry. For example, for large effusions and for complete pneumothorax, so we can directly introduce the trocar without any hesitance. If there is a partial pneumothorax or if the pleural fluid is less, then we have to mark it with the ultrasound guidance. And also, if ultrasound facility is not available, the clinical and physical examination and radiological correlation by CT or X-ray should be there to choose the point of entry. So in such conditions, like we have to first introduce a needle with syringe, and we have to withdraw. If we are sure that air or fluid is coming, like in the same space, we can, we have to remove the syringe so that to enter the air. In some conditions, sometimes there won't be any fluid. In such conditions, we have to produce artificially pneumothorax, and which can be done with a blunt tipped needles will be there, like mountain needle or Veress needle. Or we can do a blunt dissection with the finger, sweeping out any underlying the pleura. We can, with the finger sweeping, we can create an artificial pneumothorax.
Yeah.
That's correct. Can
So-
I say a point on that? Yeah,
Sir?
I've seen so many cases with a posterolateral loculations in the pleural as well as empyema also. In those cases, as Dr. Gayatri rightly said, along with ultrasound guidance, we used to go, enter
In the opposite side.
infrascapular area also for a single port also. That's a great explanation, Dr. Gayatri. Thank you.
Even though we do so many bad ref investigations, we can't expect so many few complications during the procedures. Neeti ma'am, can you say something on complications during procedure?
Thank you, Dr. Suryakumari, for the question. So I think Dr. Gayatri very well has, come up with all the complications and the meta-analysis reports. So going through the papers, we have seen that thoracoscopy is a relatively safe procedure. Medical thoracoscopy is quite a safe procedure, and the incidence of complications is pretty low. It is less than 10% in almost all studies. And they have been divided into minor complications and major complications. The minor complications are pain and subcutaneous emphysema. Many of them, which though we have not done so many thoracoscopies, at least our experience with ICD tubes, we know how to manage them. Pain, especially, it was seen when medical thoracoscopy was combined with talc powderage, then the incidence of pain was higher. And in most cases, as was already discussed, a combination of a good local anesthesia with conscious sedation would do the job. Pain was seen in a good percentage of cases. Now, the more ominous complications like bleeding and the persistence of a bronchopleural fistula, and sometimes though these two. So the first was bleeding. So let us discuss. Bleeding was seen from anywhere between 0.3 to more than 0.6% of cases in almost all studies. The largest study was done in almost 2,000 thoracoscopies by Van et al. And in that, he has said that they saw bleeding. And the bleeding site is usually in the from the subcostal vessels. And that we can often, that when you give the nick, you can see the bleeding from there. So how to manage? So that is one site of bleeding. The other site of bleeding is that when you cut the adhesions and there is a large vascular bundle in that, and then that is also another site of a bleeding. So the first, when bleeding is from the subcostal vessels, then a pressure at the nick site is good. And also we should take precautions to make the nick, which is far away from that. That is what we usually do. That is the upper border of the space. And also we should take a very good history and make sure he's not on any anticoagulants or not on any antiplatelet drugs. And most of them should have been stopped. And he should continue his antihypertensive medication as usual. So one method is like applying pressure with the finger. The other method is you can dilute epinephrine or adrenaline in 1 in 1,000, and you can put a soaked gauze and you can press it against the bleeding site. And that is one method of controlling the bleeding. And the other method, the intrapleural, the one we get when you cut the adhesions, that I think can be mitigated to a large extent by the use of ultrasound during the procedure and the use of ultrasound prior to the procedure. So this is as far as bleeding. And often, but however, sometimes bleeding can become, it can become more and uncontrollable. In such case, the necessity to convert into a VATS would be required. And thereby, it's always good to have a good coordination with the cardiothoracic surgeon, so that in case of a surgery, in case of an emergency, we have help at hand. So that is about the bleeding aspect. And the other is, I would say, maybe re-expansion pulmonary edema, which is not very common. It has been reported in very few cases. And re-expansion pulmonary edema, as we all know, if we gradually release the fluid, that's a good method. And if there is a massive effusion, then it is good that probably prior, especially in malignant effusion, when there is a massive effusion, it is good that prior to doing the procedure, 1 day or 2 days, you gradually remove 1 liter or 2 liters of fluid, so that at the time of the procedure, you don't have so much of fluid which you need to remove gradually. And the other is, there are some reports, very stray reports of port site tumor seedling, but there is not much documentation about that. So, and even that same problem existed when an ICD was also being put, that regarding the indications and contraindications, there were many papers in which it was suggested that in malignant effusions, it was questioned whether we should put in an ICD because of the, if the possibility of tumor seedling at the site, but that yet needs to be studied a lot. So these are in brief. The others, I think Madam had dealt. For paucity of time, I think I'll stop here. Thank you.
Yeah. I have a doubt, Gayatri. Is there any myth for doing fluorodesis with 100% disease will be done by medical thoracoscopy rather than by intercostal tube?
Regarding the fluorodesis, medical thoracoscopy. So in malignant pleural effusions, the added advantage is like we can do talc fluorodesis simultaneously. So there are 2 randomized control trials comparing the talc powderage, that is fluorodesis with medical thoracoscopy, and comparing with the ICD, that is talc slurry. So one is a Western randomized control trial. The other study is from the PGI Chandigarh. So in both the studies, they demonstrated that they compared these two, and then they looked at the 90-day failure rate of fluorodesis. So what they observed was, in both the studies, there is no significant difference between the two. So the one with the talc powderage is 26% failure rate, and one with the talc slurry, that is ICD fluorodesis, is 22%. So like when a case of malignant pleural effusion comes to us, once the diagnosis is done and if the patient is indicated for chemical fluorodesis, then we have to decide how to do whether medical thoracoscopic fluorodesis or ICD fluorodesis. And we also have another strategy, that is IPC, that is indwelling pleural catheter, that will also result in the ambulatory fluorodesis. So like what to do, it depends upon various factors like the staging of the underlying malignancy, the performance status of the patient, and also the patient preferences. Some patients prefer thoracoscopy, some patients prefer ICD. So patient preferences along with the survival period, how much survival is there with for that patient, and also feasibility of the procedure. So based on all these characters, we can decide. So like whichever is we can use based on these parameters.
Yeah. Sunil sir, regarding trainees, are you there, sir?
Yes, I'm here.
Yeah, for medical thoracoscopy training to the postgraduates, level 2 competency, who should give the training and to say expertise after how many procedures, like how many thoracoscopies we'll call them, or we can ask them to do the procedure individually.
Thank you for that question, Dr. Surikumari. First of all, let me thank profusely the organizers of APSA for giving this excellent opportunity and the platform to discuss about the thoracoscopic intervention to our Department of Pulmonary Medicine, Andhra Medical College. Thank you very much. And regarding this question, actually, nowadays pulmonology is running into interventional pulmonology otherwise. So there's a lot of procedures also going on along with the bronchoscopy. So basically, thoracoscopy is a surgical procedure. So where it is almost like extension of the intercostal tube drainage and all. So regarding the competency during the postgraduate time is that a postgraduate training is varying from institute to institute, and especially depending upon the infrastructure of the institute as well as the expertise among the faculty members, and hence the training as well as the experience is not uniform. But however, there should be a great exposure, and there is no guidelines actually, even though there is a ERS as well as the Indian Chest Society ATS guidelines are there. But however, usually a level 2 competency is usually advised to acquire. That means they should have a functional knowledge, especially what is the foundational knowledge, what is the topography, what is the anatomical structure of the pleural cavity, what is the three-dimensional structure of pleural cavity. Along with that, if possible, there is some kind of simulated practices and all are definitely advised. But as a guideline, at least as a supervisor performance of a minimum 20 procedures is definitely needed before doing thoracoscopy, medical thoracoscopy individually. And along with that, ongoing maintenance of the regular practice like 12 to 15 or 20 per annum is also very, very important. This kind of expertise is nowadays is advised for the all the youngsters as well as PGs who are completing and coming into practice. Actually, there's so many medical legal cases, things are there along with thoracoscopy, where medical thoracoscopy overlapping with, thoracotomy as well as open thoracotomy and all. But mainly, I request all of them to be acquainted with technical aspects of thoracoscopy, like what is the angulation of the lens, what is the how they are entering either into the pleural cavity, when to see apex, when to see base, as well as the mediastinum structures and all. These three-dimensional view is very, very important, and imagination themselves is very, very important also. So I think a multimodality approach is very important before beginning the thoracoscopy individually, and they should also go for a number of didactic lectures, and of course the hands-on simulation is also very, very important before starting thoracoscopy individually as a level of competency. Thank you, Dr. Surya Kumar.
Thank you, sir. And one more futuristic idea of following thoracoscopy in ICU, which is followed in few centers, like bronchoscopy. Can we go?
Yeah, that's a good question. Actually, so many times we are also coming across with conditions where we are unable to shift the patient to the surgery, or patient is not fit for a transport to the surgical theater and all. In those cases, I think ICU thoracoscopy can be done as a life-saving procedure and as an emergency procedure or an extension of the ICD. And especially the thing which we need to do is that you have to keep the patient on a left lateral decubitus or a right lateral decubitus while doing. And rest of the procedures, I think, should be you have to tailor them according to the needs of the patient and condition of the patient, and make sure that very important thing is that you have a bedside ultrasound during that procedure. So bedside ultrasound during the ICU thoracoscopy is also very important important tool in helping the, procedure. And rest of the things I think is very, very common and adapting to the along with the medical thoracoscopy what we are doing. And if you have a flexi-rigid thoracoscopy, I think that's a wonderful situation where you can relieve the most of the pressures in the pleural cavity also, along with vision, and you can place a ICD also. So ICU thoracoscopy is also a great entity where you have to adapt a lot of things on that, and I think it can be safely done in coming future days.
Yes, sir. So shall we take a break? We'll go for audience questions. How can
Madam,
we go
good
through
evening, madam.
audience questions? Chats.
Good evening, madam.
Good evening, sir.
Sasibaram sir, చెప్పండి sir.
Gayatri madam, congratulations for DM and joining again in Andhra Medical College.
Sir, you are not saying just on the video.
Okay.
Thank you, sir. Thank you so much.
Okay, madam. One question, madam, regarding, so there are complications which may be lesser. What type of patients we should be very careful in subjecting to thoracoscopy? And when the patient is unstable, how can we stabilize the patient and take patient in safe position to thoracoscopy?
Gayatri, unmute yourself.
For unstable patients, like for example, if the patient has a recent MI, we have to delay until 6 weeks. And if the
Yes.
patient has unstable angina, first we have to optimize the treatment for unstable angina. For example, if the patient has a chronic respiratory diseases like COPD is there, so first we have to optimize the treatment so that his symptoms should be settled, and once his saturations are maintaining, then only we can take it for a thoracoscopy for unstable patients. And for anticipating complications, like for example, if the patient is obese or if the patient has history of severe sleep apnea, in those cases, the chances of that lateral decubitus position, the chances of hypoxia and hypoventilation are more. So we have to be monitor continuously, and if needed, we can give an oxygen supplementation. And for obese patients, the portal of entry, because of the obesity, the portal of entry may be difficult. That is one we can anticipate, and then we can overcome it. And certain other complications, like if the patient has a complicated pleural effusions, if we are planning to do a medical thoracoscopy, so we have to anticipate bleeding if we do adenolysis. So if the vascular adhesions or thick fibrous adhesions, we have to avoid those, lysing them, we have to avoid. If any more bleeding is happens in such cases, we have to always keep a backup of a CT surgeon friends for that. And any coagulopathies are there, we have to delay the procedure. First, we have to treat the coagulopathies. Once they're stabilized, then we can proceed. So the minimum platelet count should be more than 60,000, and then INR should be less than 2 or less than 1.5. It should be there. If it is more, first we have to treat.
Okay.
Gayatri, guidelines stating regarding the patient when you can take after MI, how many weeks after?
Wait for 6 weeks, sir.
As usual, okay.
So you have to wait for 6 weeks.
Okay.
Thank you.
Go ahead.
Thank you, sir.
Mr. Nitin, any questions from the audience?
Yeah, Dr. Gopal Krishna, one questions I have received, I think go for that. How do recent advances like uniportal or video assistant thoracoscopy surgery like VATS improve the patient recovery and procedural efficiency compared to conventional approaches?
Thank you, Kaja.
Please repeat the question, sir, once.
Ma'am, the question is, how do recent advances like uniportal or video assisted thoracoscopy surgery like VATS improve the patient recovery and procedural efficiency compared to conventional approaches?
Conventional approaches means the cytology, pleural fluid cytology, and the closed pleural biopsy. The first thing is like the uniportal means the medical thoracoscopy. The VATS is a multiportal. So basically the difference is medical thoracoscopy is predominantly diagnostic, And VATS is a predominantly therapeutic tool. So in case of medical thoracoscopy, we will do under local anesthesia in an endoscopy suite, whereas VATS will be done by a CT surgeon in an OT under general anesthesia. So both are completely different strategies. And coming to the recovery of the patient, so either VATS or medical thoracoscopy for the patient good recovery, we have to, patient selection is very important. Like we have to pre-evaluation of the patient or pre-procedure evaluation is very important. We have to see whether the correct indication is there or not, any comorbidities are there, any contraindications. We have to see all the pre-operative workup we have to do thoroughly to avoid all complications associated with this procedure, so that we can that the recovery will be good in either VATS or in case of medical thoracoscopy. And in medical thoracoscopy, there are two types of thoracoscopies available. One is the rigid, one is the flexed or semi-rigid thoracoscopy. So the main difference between the two is the size of the biopsy specimen. So to increase the diagnostic yield of semi-rigid thoracoscopy, there are some adjunctive instruments are there. For example, like a cryobiopsy or a diathermy knife. These things can be used to increase the diagnostic yield so that to get a bigger sample and a better diagnostic yield.
Thank you very much, ma'am, for your clarity.
Just want to add one point over there, sir. Actually, these are the two things, sir. Medical thoracoscopy and VATS are other two extremes of the procedure. But in between, while pre-operative evaluation, only one has to do, two mandatory procedures like bronchoscopy as well as CT scan. So this will simplify the case whether patient is having a multiple problems like adhesions or something, or interbronchial pathology or something like that. Then we can plan whether we go for a medical thoracoscopy or a two-port technique of rigid thoracoscopy or a VATS also. So this is how we can plan, some of the cases actually.
Yes, sir.
So,
Yeah, Neeti ma'am, can you throw some light on the VATS versus medical thoracoscopy? It's a very broad topic to discuss, concisely.
Madam, as of now, basically VATS is basically a surgical procedure usually used for larger surgical problems such as pneumonectomy or wedge resection or partial pneumonectomy, and for other surgical procedures such as sympathectomy and all those. And medical thoracoscopy, as madam already said, is a predominantly diagnostic procedure, and with we can do minimal corrective things like especially in the early stages of empyema or in the early stages, then when you can do small adhesionolysis or removal of adhesions. But for anything more complicated than that, it is better to go for a VATS, in which you can do a large procedures. As madam already said, the number of ports are more, so then you can put in instruments and do other things. So I think more or less that summarizes it all.
Yes.
Madam, one question from my side. If the patient is coming with a large pleural collection after a trauma, what exactly is the thing? Should we go for a aspiration, confirm it is pneumothorax or a pleural effusions, or going for a thoracoscopy? What is your take on that, Dr. Neeti?
Sir, my opinion is, sir, post-traumatic usually is the surgeon's prerogative, because when it is post-traumatic, we know we cannot be sure that it is localized to that extent. Usually, I'm sure they would need an exploratory surgery to find out if there are other other injuries, rib fractures, and whether they need to fix the multiple rib fractures, whether there is a flail chest. So I don't think that as physicians, we should, in post-trauma, I don't think we have much of a role, sir, as of now.
Actually, there are so many cases where some of the cases where post-traumatic pleural effusions found to have a malignancy also in last 10-15 years.
So that could be a coincidental finding, but for trauma per se, I don't know that whether we should, summarize it with the and like if it is only trauma has developed only pleural effusion, then probably we can go with the conservative method of doing a pleural aspiration and further diagnosing it. But if there is a large pneumothorax, it is associated with multiple rib fractures, I think it is better to hand it over to a surgeon.
So what you said is multiple refractions is one which is very, very guiding here.
Yes, sir. So that I think surgery people should deal with it, whether with K wiring or with some other, orthopedic or surgical techniques, sir.
Because whenever you start doing thoracoscopy, there's a fine line of difference between the pulmonologist doing thoracoscopy as well as the when to handle case to thoracoscopy surgeons and all. Thank you. Thank you.
As the expertise, can you throw any opinion on BPF in medical thoracoscopy
BPF.
treatment wise?
So BPF itself is a very, great chapter actually, Dr. Surya. And actually, thoracoscopy is a very good versatile tool in dealing with the bronchopleural fistula. Why? Because it is usually aids in identifying the BPF and associated that it can help in clearing the associated infected pleural collections also. That is also very, very important. So whenever you do ICT for BPF, it may not drain all of the collections and all infected material. So ICD versus thoracoscopy in BPF, I think is very, very important and definitely the better tool for clearing the all infected pleural collections and all. So it has the two advantages like drainage as well as the closure of the BPF also. So these are the two things what we have to entertain when you're doing a thoracoscopy in BPF. So there are so many methods of closure like tissue glue as well as bronchoscopically occluding with the spigot and all after giving any dye and all. However, thoracoscopy can be used to drain and debridement of the entire pleural cavity in case of BPF also. So and those cases of BPF we can see if you are not able to do anything by thoracoscopy like cure and all, I think you can plan for a thoracotomy by handovering the case to the surgeons also.
Yeah.
And after thoracoscopy also there are so many air leaks may occur. I think you have to wait for a closure of those post thoracoscopy air leaks for a couple of weeks time, and then if still it is persistent, then I think you can hand over the case to either redo or a thoracic surgeon. That's my take. Thank you, Dr. Suryakumar.
If there are no questions from audience side, then we go to the end of the session.
Yes, ma'am.
Yeah.
What are the
So-
recent advantages to Dr.
Yeah,
Suryakumar?
yes, that's what I'm going to tell you.
Yeah.
Like even with these vast investigations, doing exploratory medical thoracoscopy, in few conditions we are not able to diagnose even 30% of the cases we are missing. For those, we have recent advances like robotics, artificial intelligence, or already Gayatri has discussed about autofluorescence techniques. So by this, if we can use those kind of latest equipment, we can at least diagnose in a earlier stage of the carcinoma, or it can be a metastatic carcinoma or pleural malignancies. We can take biopsy from that site. In the regular white light medical thoracoscopy, we cannot identify those lesions. So as she showed a slide showing different colors in autofluorescence thoracoscopy. So at that site, we can take the biopsy for early diagnosis. Regarding robotics, if we use robotic surgeries, we can have a well dexterity, like a movement of movement of the different corners of the thoracic cavity, and we have a very she has shown the 3D images, like three-dimensional image of the pleura also we can do in robotic surgeries. So at recent advances, we can go through the entire thoracic cavity, wherever it is, we can locate, I think. These are the latest equipments to come in. And not only that, we have injecting a virus like herpes simplex, which has got the anti-tumor effect. We can locate the tumors. So it is in research now in New York since 2005. So if we can detect the tumors in the early stage, we can take biopsy from that also. So these are the latest advances in thoracoscopy, which we have to explore.
Yeah, that's great, very nice. And Dr. Gopal, how about your experience of advanced thoracoscopic procedures and especially robotic procedures as you are actively engaged in intervention pulmonology in your region actually? Please throw some light on the robotic or advances.
Thank you, sir. Thank you so much. Actually, robotics, VATs, and uniportal VATs all are belongs to the surgical field, sir. But now robotics are like picked up the thing, and so the accuracy and precision of the lesion and the cutting edge technology of robotics has nowadays the centers of the robotics have increased, and especially very useful in malignant conditions. So we can have a like a very precision cut with the robotics. So very useful for the surgeons, especially when dealing the malignant cases. And for being a physician, robotics, I think we don't have much roles, especially in VATs and robotics. But for surgeons, it's I think now in coming future, many hospitals is going to have that robotics.
Why? Because there's so many cardiac thoracic surgeons are doing only cardiac surgery rather than thoracic surgeries nowadays. I think we should have improved versions of approach towards the thoracic, pleural cavity problems especially. So I think we need to upgrade our thoracoscopic procedures much more faster and much more advanced in order to address most of our patients who are suffering with a chronic empyema or something like a chronic collections as well pleural cavity.
I
So
think
can I
we need to have a we need to separate the cardio surgery from thoracic surgery, sir. Need to have a dedicated thoracic surgery specialty for the surgeons. Then only the number of surgeons will increase.
but
Yeah,
it is our
yeah,
request last 1 decade, but no good number of thoracic surgeons are coming across in all the areas I suppose. That is the main problem. What
because
we need.
nowadays there are so many cardiac surgeries, and as one cardiothoracic surgeon said, that cardiac surgeries, you can discharge the patient in a short while, and then there are no chronic infections which require long-term inpatient, and the cases are not so complicated. So when it's cardiothoracic, they prefer to do the cardiac rather than the thoracic. There are very few surgeons who are concentrating on the thoracic aspects, I think. You're right, Gopal. Thank you.
Yes, madam. With the advances of this uniportal VATs and robotics, nowadays the post-operative stay is very much reduced
Very
in
much.
thoracic surgery. So an average post-operative stay in our hospital is not more than 5 to 7 days. It's like cardiac surgery. Any patient can be discharged within 7 days. So I think nowadays it's not there is no much difference between the thoracic and cardiac surgeries, madam.
Yeah. Gopal, you have any experience over medical thoracoscopy on diagnosis of lung diseases like ILDs, DPLDs, or have you taken
Yes, madam.
biopsies with clips like that, or you didn't explore?
Yes, madam. We are doing lung parenchymal biopsies, especially in patients with ILD. The medical thoracoscopy is a good tool. So with our simple forceps, we can take the biopsy of a lung parenchyma. Usually, it won't cause much problem. So far, I think we have done more than 20 to 25 cases of medical thoracoscopic parenchymal biopsies. But so far, there is no any post-operative complications. Most of the patients, we removed the ICD on the second post-operative day. There is no any air leak or any bleeding complications with the medical thoracoscopic lung biopsy. I think safely we can do the procedure, madam.
That's right. Dr. Bharat, what is your take on this recent advance as well as segmentectomy or what you call lung biopsies or the thoracoscopy as
So
Gopal
for
has said?
yes, sir, for beginners, it is always not advisable to do it, sir. Once you are trained enough and you have a CT surgeon as a backup, so it is possible to do, sir. Because even in our interventional pulmonology fellowship, they were doing, sir, but it was done in a very controlled center where everything was available within minutes, sir. So then we can attempt, sir. But as you already told that. So there is one border that we have to delineate among ourselves. So this is a zone that I should not touch. And once you are in a well-equipped center and you are very much efficient, so no issue in doing it, sir. So at least lung biopsies.
Most of the thoracoscopy is having a problem of dense adhesions also when we go inside. So I think one should have a good expertise in doing instant decisions about adhesive and all that.
Yes,
What
sir.
is your take, Bharat?
Yes, sir, definitely, sir. Because there can be torrential bleed sometimes, and these bleed, it is very difficult to control, sir. So if you are in doubt that this additional lysis is going to cause a bleed, it is better to omit. Otherwise, which are very thin and which you can see the base very well, so that things you can touch, sir. If it is vascular and very thick adhesions, so I think there is no point in trying to touch it when you are in a resource limited setting.
Actually, whenever there is a thoracoscopic bleeding is occurs, the first thing is that we should not get panic. Why? Because actually that is I mean, the lens is magnifying the problem there. So it is always better to try to control this thing, as well as then we have to hand out the case or something like that. So that is also very, very true.
As long as we, yes, sir, as long as we confine to the lateral pleura, it won't cause much bleeding. So because if suppose if cause bleeding, it is the bleeding from the intercostal vessels. Usually will stop after point of time. If you go towards mediastinal pleura, then the damage will be more and you'll get a more bleeding. So try to avoid the mediastinal portion and be stick on to the lateral portion or lateral chest wall.
Yes, sir. How about are you using any W tube anesthesia techniques for doing thoracoscopy in your centers, Bharat and Gopal?
No, sir. In our center, most of things we are doing under conscious sedation and single port, sir. And we have CT surgery team also. So when we feel that this patient requires anything more than that, we are handing it over to them, sir.
We are using the WMN and as well as the blockers in our institute, sir. For a regular biopsy, we don't use any blocker or anything. Suppose if you want to do any advanced thoracoscopic procedure like addition lysis, decortication and all, then we are using WMN tube or bronchial blocker. And sometimes we'll use the CO2 insufflation, the same like laparoscopic procedure. The CO2 can cause the collapse of the lung. That is useful for simple addition lysis. But for a complicated addition lysis, we need to have a WMN tube, sir.
Dr. Gopal, are you doing cryo procedures nowadays in
Sir, I did not get. Sir?
Are you doing cryoprobe biopsies in thoracoscopies now in your practice nowadays?
Yes, sir. Yes, sir. Yes, sir. Cryo is having its own advantage, sir. So we can get a big chunk of tissue and there won't be any crush artifacts. So cryo, if you have, you can utilize, but try to stick the cryoprobe on the rib surface, not on between the intercostal spaces. So it's going to cause the severe damage to the intercostal vessel and nerves. So if you want to use the cryoprobe, better to stick the cryoprobe over the rib, not between the spaces, not between the ribs.
But what if you are finding only one lesion that is only a diaphragm and thoracoscopy? Would you like to do biopsy or is there any alternative procedures? Only
Again, depend.
on the diaphragm, then what to do?
Yes, sir. Again, depends on your competence and backup support, sir. If you are okay and if you are having enough experience, then you can touch the diaphragmatic lesion. Otherwise, if you are a learner or a basic thoracoscopist, it's better to avoid the diaphragmatic lesions.
My question to Gayatri, is there any yield in biopsy procedures? I mean, after doing a biopsy, is there a difference of yield between the anterior portion, posterior parietal pleura or basal? Is something like a topographically, is there any difference in yield of, pathological results after taking biopsy?
It mainly depends upon how the pathology of the underlying disease. For example, if it is a tuberculosis, the distribution of the lesions is uniform. So wherever like abnormality, you can take it. Like even closed pleural biopsy also, the yield is good with you. Whereas in case of malignant pleural effusions or malignant metastasis, the lesions, metastatic lesions are predominantly in the lower zones of the lungs, especially in the diaphragmatic pleura or posterior costovertebral parietal pleura, all those lesions. That's why the portal of entry should be little lower in case of suspected or malignant pleural effusion. So there is no obvious abnormality. If we can take from the lower zones in suspected malignancies, we may get a positive yield. In the same way for malignant mesothelioma also, like it is also a diffuse disease, because like, but in case of malignant mesothelioma, it looks like some chronic inflammation sometimes rather than an obvious abnormality. So in those conditions, like we can take from the chronic inflamed pleura, but the diagnostic yield will be less. That's why in case of mesothelioma, the advice is to take a larger pieces. So if you're suspecting a malignant mesothelioma, you have to choose a rigid rigid thoracoscopy rather than a semi-rigid thoracoscopy.
Yeah. Nowadays, we are doing only EBUS, a peripheral nodule, more than 1 centimeter, something like that, Gopal. So, would you like to do any thoracoscopic biopsy of lung if the peripheral nodule is less than 1 centimeter? Something like that?
Yes, sir, but it's very difficult to pick up a less than 1 centimeter nodule in thoracoscopy. Sometimes we need to localize the nodule before going to a thoracoscopy, like putting a needle or putting a small guide wire into the nodule. Otherwise, it's very, very difficult to pick up the nodule in such a big lung. So it's ideal proceed with the radiological guidance, especially if it's a smaller nodule. Or we can use some like dye injection, like fiducial techniques and all to locate the nodule.
I think there's something like IVAT is there, image guided VAT procedures also, where they're going to pinpoint the.
Yes, sir, maybe. Yeah.
That's an excellent. Thank you very much, Dr. Gopal and Bharat, for clearing most of my doubts on this platform. Thank you. Over to you, Dr.
Thank you,
Surya.
sir.
Over to you, Dr. Surya Kumar.
So I think we have covered maximum. Sir, Gopal, have you come across any giant bullas in view of opening?
Madam, 1 second, please. Yes, madam.
Have you come across any giant bullae by opening a case of pneumo?
Yes, madam. We usually will do a CT before any pneumothorax thoracoscopy, but sometimes surprisingly some bullas will be bigger than expected. So obviously we have to depend on the surgeon that time. So you should have a backup surgeon whenever you are doing a thoracoscopy for a pneumothorax or a BPF. So if the surgeon is available, so we can finish the work in the same sitting instead of waiting for the second procedure. The surgeon is available on site, so he can close. He can come and he can do the bulectomy, or he can close the BPF on the same sitting. So it's try to involve the surgeon if we are doing a complicated case of pneumothorax and all, or BPF.
Or any LVRS through bronchoscope?
Madam?
Umbrellas?
LVRS.
Yes, madam.
Yeah, through bronchoscope.
Yeah, through bronchoscope. Yes, madam.
Okay.
So we can guide with bronchoscope, and the surgeon can do the procedure.
That's what.
So I just want to add a point here. Actually, in the last 3 years, in our institute, Andhra Medical College Chest Hospital, we have been doing the thoracoscopy under the DLT support, WM tube. Almost we have done 38 cases so far, sir. And most of the cases, we are happy that there will be big space for negotiation of our, instruments and all through that. And it's also a good learning aid for the youngsters to see and know what exactly how best we can do. Also, so we are going to put a presentation of paper publication also for that, sir, on those procedures. Just to add a point here. Thank you.
Great, sir. So from a government hospital using the WM and tube and all, like you are very much advanced in thoracoscopy. So AMC has created a milestone in thoracoscopy, I think.
Added flavor is that most of the anesthesia PGs as assistants are coming down here to do DLT and the guiding by the ambu bronchoscope also to see the positioning and all. They're also very happy to do that. So we are also happy at the end of the day. So that is the thing actually. So thank you very much.
Thank you so much, sir. I think we'll close the session. Dr. Bharat will give the closing remarks.
So first of all, congratulations to Dr. Gayatri Madam, because it was great to know that you are the first DM in government service, Madam. So you will be inspiring a lot of younger generations that after MD, DM, we can still teach in government service. And your presentation was very crisp and very engaging. I hope all the residents sitting out there, they got both inspired by your presence and also they got enlightened by the knowledge that you have shared. And to the panelists, very energetic and very enlightening discussion by our moderator Surya Kumari madam, Niti Chandra madam, and our Sunil sir. Sir, what you have showcased in this one presentation shows the efforts that you have taken all these years. So because that experience will only come by years and years of practice, passion, and all the efforts that you are making to make sure that a government college can be the #1 pulmonology institute in the region. So thank you so much, sir, for your leadership and guidance. You are an inspiration for younger generations like us. And to Gopal Krishna, sir, for taking all the efforts from APSA and Rajendra Prasad, sir, our Andhra Babu sir, Subbarao sir, everybody for bringing this platform together and looking forward for more such engaging discussions in the future, sir. So thank you, sir. It was great honor to share the stage along with all of you, sir. Thank you, sir.
And
Thank
I do
you very
remember
much.
Dr. Bharat, the moment we are doing thoracoscopy workshop in 2024, Nellore APSA,
Yes,
on my word, you have arranged a watermelon model also
yes,
for
sir. Yes.
to learn how is the thoracoscopy. That's a very memorable event for me, Doctor.
For
Thank
us
you.
also, sir. So thank you, sir. Yes.
Thank you very much, Bharat sir, for your appreciation. Thank you, sir.
Thank you.
Thank you,
Thank you
Gopal
very
sir.
much.
Thank you, Nitin and Kadil sir. Thank you. Thanks for
Sir,
wonderful.
thanks. I will take you just 1 minute because I was mesmerizing because I was as if like I was sitting in the galaxy of eminent pulmonologists, and Doc Plexus is honored to host this type of program on our platform. Thanks to Dr. Gayatri for an interesting presentation. Thanks to Dr. Ramakrishna sir, Dr. Sunil sir, Dr. Niti ma'am, Dr. Surya ma'am, and others for your valuable inputs. And my special thanks to Dr. Gopal Krishna, Dr. Bharat Kati for making this session successful, and all other esteemed faculties for their precious time. So my sincere thanks to all the founder member and faculties of APSA. And I'm sure that this will help across India, SCPs across India to utilize the learning of thoracoscopic intervention. And those who have missed this knowledge, sir, they can see it recorded on the DocPlexus platform on the past event series. It will get remain recorded on our platform, sir. So I look forward for more this type of session on our DocPlexus platform. Sir, I will request, we will go now offline and I will request Sunil sir to be remain there. I had one feedback from your side.